Success rates were low in the beginning. Really, if we could say 20% of couples would come out with a baby, that was fabulous.
I'm Jill Angelo, host of the Geneve podcast series for women's health in midlife. I speak with the most forward-thinking experts in the health and wellness industries. These experts are helping women 40 plus feel confident and in control of their health in the most vibrant years of their lives. So join us on this journey of women's health. Back in May 2017, I spoke with Dr. Lora Shahine on IVF, fertility, and the stigma around miscarriage. You can hear that podcast on Geneve.com. The topic proved so popular with the Geneve community that we returned to Pacific Northwest Fertility to talk with Dr. Lorna Marshall on egg preservation and the options women have for planning their families and their futures. Hear part 1 on the science and challenges of freezing a human egg. Thank you, Dr. Marshall, for being with us today. Let's start first with your specialty in fertility. Tell us a little bit about your trajectory and your career and how you came to, I think what we'd love to talk most about today is egg preservation and egg freezing, but what brought you to that specialty?
My training is in obstetrics and gynecology initially, and then I subspecialize in the field of reproductive, endocrine, and infertility. So that's a specialty that a fertility specialist officially has. So how did I get there? Well, the interesting thing for me is that I graduated from medical school in 1979, and the first IVF pregnancy was in 1977.
Wow.
So I feel like my career has followed the entire history of in vitro fertilization, so I must have been destined to do this for a living. And in fact, when I first went into obstetrics and gynecology, I had very little interest in infertility. It was kind of boring. Basically, you just gave Clomid, you did a little surgery. You didn't help many people.
And sorry, why didn't you help many people? Was it just not a thing then?
Because so many things were unsuccessful. Like women would have tubes that were damaged, and we would do microsurgery after microsurgery, 3 hours, 4 hours, 6 hours of surgery, and they wouldn't get pregnant.
Wow.
So IVF started then in the United States, and I actually started my fellowship in San Francisco in 1984. And when I arrived in San Francisco was when the first babies were born from IVF that was done in San Francisco. I really started off doing research in neuroendocrinology. That's what I was interested in. But as time went on, in vitro fertilization got more and more fascinating, and has the science, the ethics, and the clinical practice have all become so fascinating that it has provided me with a very rich and interesting career where I think I've helped many, many couples and individuals start families over the past 30 years.
Wow, that's fantastic. Yeah. People who didn't think they'd have a family.
Right. Success rates were low in the beginning. Really, if we could say 20% of couples would come out with a baby, that was fabulous. So it was really a treatment for the adventurous souls, and not for mainstream folks that were just looking for another way to have a child. So it was very fascinating to sort of move from that into today, where everyone is used to solving problems with technology. It's very different.
And even in those 30 years, has the profile of your typical patient changed in terms of age or in terms of having tried for a certain period of time? Or how is your typical, I guess, is there a typical patient is question number one, but how have you seen the people you've helped change over time?
Some, not as much as you would think. So the folks that came to us to get pregnant were still everyday folks, and they still are everyday folks. We would help them get pregnant with simpler therapies, with clomiphene or with inseminations or with surgeries for a long, long, long time before they would resort to doing something like in vitro fertilization. Many of the couples that came to us early on had tried for 8, 10, 15 years, maybe had been to multiple physicians. And then when they came to us for in vitro fertilization, they had gone through an awful lot. Whereas now you see couples who have tried maybe 6 months and are like, well, should I be doing in vitro fertilization to get pregnant? So they're just embracing something more complicated much faster. The issues in a lot of ways are still the same. It's money. The issue is still money. And
those that can afford it
yes,
are looking at it as
past,
an option.
Insurance companies would usually pay for things like Clomid and surgery and basic treatments for infertility, but they didn't pay for in vitro fertilization. There are now more companies in the state of Washington that pay for in vitro fertilization, but there's still a lot of companies that don't. And a higher percentage of the patients who come here to our clinic are covered by insurance, but still the vast majority of folks that are out there wanting to have children do not have coverage for infertility. And still what's sad is that we can't help everybody.
Yeah. How about women who are proactively coming to preserve their eggs? Because that's probably a different audience, because you're talking about the couples that come to you that say, we've been trying to have a child, whether it's 6 months or 15 years.
Yes.
But now you have this new community of women who are coming in more as a preventative.
Exactly. So in the past, I think we really just dealt with infertility, and now more and more we deal with individuals and couples who are looking for their reproductive options and are not necessarily infertile when they come into our clinic. So we almost have two groups of patients in our clinic, those that are the more traditional infertile couples or individuals, and then those who are trying to plan their reproduction for later years.
And the ones who are planning, are you seeing them? Well, typically, I would assume if they're planning for the future, they're trying to do this while their eggs are still, quote unquote, good or healthy, if they want to extract or preserve any eggs. Like, what does that woman look like? Is she usually young and in her profession already, or how are they thinking about planning for the future?
It has been changing. So I think initially, when the option for elective fertility preservation by freezing eggs became available, which was really very recently, 2012, so 5 years ago.
That's not very long.
So as a profession, we've been able to freeze sperm for a very long time. So since the 1940s, 1950s, I think the first pregnancies from thawed frozen sperm were in the 1950s. Sperm are very small cells, very easy to freeze. The problem with traditional freezing methods is that there can be ice crystallization that can destroy the tissue. But since sperm are small, that's pretty easy. And plus, usually you have a lot of sperm, and so if you lose a few of them, it's not a big deal. Once we started doing in vitro fertilization, at first we couldn't freeze embryos. The first pregnancies from frozen embryos were in 1984. And embryos are pretty easy to freeze. Initially, we froze them in the multi-cell stage, which means 4 to 6 cells, but then with time we realized the best time to freeze an embryo is in the blastocyst stage, which is a more advanced stage of the embryo. The first pregnancy from a frozen egg was in 1986. So very soon after we learned to freeze embryos, bam, we're freezing eggs. And we learned that eggs were the hardest thing to freeze in terms of cells in the human body. The egg is the largest cell in the human body. By being so large, it's very prone to ice crystal formation in the freezing and the thawing process. So we were very concerned that freezing and thawing eggs would result in abnormalities in the embryo. And that's part of the reason why pregnancies weren't successful.
And why would the embryo freeze better or more?
The cells are smaller. So if you look at an egg is about the same size as an embryo, but an embryo will have 8 cells or 150 cells in the same size. So the cells in an embryo are smaller than the cells in an egg. Still the survival rate of embryos was not 100%. It was sort of 40%, 50%. As we learned more and more, we got better. We learned how to program the freezing and the thawing methods so that we would spend a certain period of time to minimize ice crystal formation. And we call those methods slow freeze methods. So, for example, in this program, we have been freezing eggs since 2005. We initially froze them for cancer patients only, under sort of experimental status where the patients would sign a consent.
And that was because the chemo that they were
Right.
presumably going to go under would kill the
Exactly. We would never
eggs.
have at that point considered freezing eggs for somebody who just wanted to delay their fertility.
Mm-hmm.
So we took care of young women who were in their 30s, early 40s, who had the diagnosis of a cancer that required either chemotherapy or radiation therapy that would be toxic to their ovaries. And it was fairly certain that they would not be fertile after they completed that treatment. So in order to give them some hope of being able to have a child, we would freeze their embryos if they were partnered, but then we would freeze their eggs if they were not partnered. We used the old slow freezing methods, which are not very successful. We couldn't learn much about it because these women often didn't come back for many years, and we weren't thawing them and establishing pregnancies. So it was very unsatisfying, and we felt like we weren't moving forward very fast in our science of freezing eggs. So in the 2005, 2006, some programs started doing what we call vitrification, which is a different way of freezing eggs. It's a flash freeze where we use a protectant to the embryo when we freeze the embryo, like an antifreeze sort of thing, and we do it very rapidly and then rapidly freeze the egg, and by doing so, it prevents the ice crystal formation that we saw with the old slow freeze methods. So in our program here, we started vitrifying eggs in 2009. And we did it because we wanted to get better for our cancer patients so that we can help them more than we were able to help them.
And you wanted the success rates essentially
Right.
to go
And
up.
at this point, our professional societies still considered that freezing eggs was experimental. And that experimental designation was only lifted in January of 2013.
Wow.
So
And what lifted it eventually? Was it a number of successes?
exactly, there was enough data with freezing eggs that used this process of vitrification that our professional society felt that it was reasonable to offer freezing eggs. They still didn't advise that we offered freezing eggs as an elective procedure. They were just saying this is very reasonable to use for patients with cancer, for patients who, there's no sperm at the time of an egg retrieval and you don't want to throw away the eggs, so let's freeze them. We have some couples that go through an IVF cycle and they get a lot of eggs and they don't necessarily want to fertilize all of those eggs because it's very troubling then to have extra embryos that you don't really know what to do with. So they advise that this is a reasonable application for freezing eggs. Or perhaps somebody who has not necessarily cancer but has a family history of early menopause, or they have endometriosis and they're worried that they're going to have to lose their ovaries at an early age, then maybe that's reasonable to freeze eggs. Our professional society still hasn't come out with a blessing for elective egg freezing.
Even here in 2017.
Well, that's only 4 years later.
It's
It's not much later.
That's
I think
crazy.
it's good for women who are in their 40s or approaching 50 to realize they couldn't have frozen their eggs when they were younger. When Janet Jackson,
no regrets.
no
like,
regrets.
Don't
They should have
regret
no
it.
regrets. So
Yeah.
Janet Jackson, when she gets pregnant at 50, everyone's like, "Oh my gosh, she must have frozen her eggs." Well, she couldn't have frozen her eggs because that wasn't available when she was young enough to freeze her eggs. So really, this has only been around in a non-experimental basis and appropriate for programs to use it for elective egg freezing for 4 years.
Thanks for listening to part 1 of my conversation with Dr. Lorna Marshall. In part 2, we talk about how egg freezing is no longer just for women facing the end of their fertility for medical reasons. Now it's become a true family planning option for healthy younger women wanting to postpone pregnancy. Stay tuned to hear more. Thanks for listening to the Geneve podcast series. We welcome your feedback at geneve.com. That's GENNEVE.com. You can follow us on Facebook and subscribe to us on iTunes or Stitcher, and you'll never miss an episode. The Geneve podcast series is produced by Shannon Perry. Theme music by Smitty. And until next time, watch the Geneve website for new stories and offers all dedicated to women's midlife health.